Peptic ulcer disease, there are two of these. We have gastric and duodenal ulcers. Let's start with how do we get them? Majority of the cases are caused by either NSAID use. By NSAID use, we mean chronic NSAID use. It's not occasional use of Aleve or any other NSAID that you take. This is habitual. Okay, so who would these people be that take it regularly?
People who are on like aspirin. No, no, no.
Okay, so usually rheumatoid type, yeah, inflammatory diseases like rheumatoid arthritis. Who else? We have people with osteoarthritis as well. Okay, yes, ma'am. Women with oh yeah, as long as that person is taking it habitually, okay, meaning 4 or 5 times a day for a number of months or years. How it happens is NSAIDs are work by inhibiting prostaglandin, which is a neurotransmitter for pain. Prostaglandin also happens to be a vasodilator. So if you're taking NSAIDs, so you're doing the opposite effect, which is causing vasoconstriction, and that has damaging effects on microcirculation, namely your kidneys, which are made up of nephrons, correct? So if your nephrons are microscopic, then the capillaries that supply the nephrons are also microscopic. Same thing also for the mucus producing glands in your GI tract. The mucus that protects our stomach lining from our own acid also rely on constant microcirculation. So those are also affected by NSAIDs. And lastly, your heart also. Heart disease has been linked with chronic NSAID use. That is, if you have an underlying or pre-existing heart condition and then you take NSAIDs, that increases the incidence of cardiac events, meaning heart attacks. H. pylori is the other causative factor in the development of peptic ulcers. H. pylori is a bacterium. We most of us have them in our gut. They just don't cause any infections or any problems unless our immune system drops. Okay, so these are, well, they're not exactly opportunistic infections, but they just lie dormant and then they just wait silently until they burrow into the lining of your GI tract, and that's how they cause infections. Now, how do you describe an organism like that can live in the stomach or the small intestine in that acidic environment? What can you say about this organism? Is this a normal flora?
So part of this also. Or is opportunistic.
If I miniaturize you and then I stick you inside the stomach and have you live there, what can we say about you if you survive that environment? Are you a weakling, puny?
Strong, okay.
Are you a badass
Yeah.
organism? Yes, you're a badass organism. All right. Now, it's not really true because most people think that your personality causes you to have ulcers, like type A personality, for instance, or a high stress environment. Look at this statement. In the past, stress and anxiety were thought to be causes of peptic ulcers, but research has documented that most peptic ulcers are caused by H. pylori infection as well as chronic NSAID use. There are other forms of ulcer, but for our purpose in chapter 40 is simply talking about peptic ulcers. So like I said, the ulcers form either from death or destruction of the mucus producing glands in your GI tract, causing the absence of mucus lining in certain parts of your stomach or small intestine, and causing them to be exposed to the acid, causing corrosion, ulceration, eventually perforation and bleeding. The other, of course, is from H. pylori, which again burrows into the lining of your GI tract, particularly the stomach or the small intestine, causing ulcerations, okay, exposing that again to the acid. And once the acid erodes the mucosa, the lining of your stomach, then bleeding will occur because now it exposes the blood vessels to the acid. Then bleeding will occur, and then eventually this will perforate, and then we'll talk about a few more complications related to peptic ulcers. Manifestations. Now, depends on what type of ulcer do you have. Is it a stomach or a gastric ulcer or a duodenal ulcer? The main difference between the two is the onset of the pain. Now, let's review normal physiology. When we eat, how long does food stay in the stomach before they enter the small intestine? So about 1.5 to 2 hours, okay, on average. Now, what is the food doing in the stomach during that time? They are turned into liquid. When they're liquid, so about 1.5 to 2 hours later, they now enter the duodenum in liquid form, ready for absorption. So it would make sense that when would you feel the pain if it's a gastric ulcer? How far from a meal? So what does this paragraph say?
There are.
So if you have a gastric ulcer, why does the pain occur immediately after eating?
Goes down after passing through the.
When is the acid produced? Once you start chewing. Okay, so gastric acids are produced, so therefore makes sense that when would the pain onset be? Okay, immediately when you start eating, then there will be pain. Now, why is the pain in duodenal ulcers occurring 2 to 3 hours later after a meal?
That's when the food gets to the.
Okay, because the acids has not been released yet until the food that was in your stomach enters the duodenum. Okay, so the pain, therefore, or the onset of pain is directly related to your physiology, okay, the peristalsis, the timing of your peristalsis. Okay, here are other associated symptoms. So besides pain, you have dyspepsia, you have vomiting, constipation, or diarrhea. Please read the other manifestations yourselves. How do we diagnose it? We have to see the ulcer. So an endoscopy will be done. Either the doctor does a traditional endoscopy, meaning put the scope down your throat and then visually see and locate the ulcers, or they can do an advanced minimally invasive procedure, which is called a pill endoscopy. They have you swallow a pill, and then they take the pill gives information to the physician, whichever one is preferred. How is it managed? Well, depends. What did the doctor find as your risk factor? So they do your history, their interview. So are you taking NSAIDs? Then do you think is the part of the treatment? Okay, can we afford to stop though for certain people? Can a rheumatoid arthritis patient afford to stop? Okay, so what would be an option for those people? They have to take NSAID. There's no other drug that will work for arthritic pain. Okay, so we'll get to the medication shortly. Well, that would be one option. And of course, if it's H. pylori, since this is a infection, what will be part of the treatment?
Antibiotics.
Okay. So let's look at the treatment based on the particular cause. All right, so if it's H. pylori, then that would be treated with 10 to 14 days of dual or triple therapy. When we say triple therapy, it's actually dual antibiotics. Now, why two antibiotics?
Because it's strong.
Again, it's a badass organism, so it needs to be treated aggressively. So we'll use two GI antibiotics. And this is always a combination. Okay, you cannot interchange. These are based on these are standard protocols. Okay, so the doctor has a choice of either flagyl or metronidazole or amoxicillin and clarithromycin. So they can do metronidazole with clarithromycin or amoxicillin with clarithromycin. Right? And there's always a PPI with it. So that's why it's a triple therapy. So it's always dual antibiotics and a PPI, or the doctor may choose an H2 receptor blocker, which has the same effects as PPIs, but of shorter duration. Right, we have a whole table of the combination medications shortly. Yes.
The H2 receptor blockers are the green, right? The lab.
Yes. Okay, so we have here table 40-3. These are the combination antibiotics. And that's the duration of the treatment. So it's a drug chart or a table. So what are my questions? Okay, nursing considerations. Okay, let's look at the quadruple therapy. Now, bismuth salicylate, or we can also use misoprostol. Misoprostol is the abortion pill. Okay, so therefore, what is misoprostol therefore? This was not invented as an abortion pill. This was intended because this drug is a prostaglandin analog, meaning instead of the NSAID inhibiting prostaglandin, this is doing the opposite. Okay? So therefore, for people with chronic illnesses wherein they have to take NSAIDs, they will be given misoprostol together with it. Of course, the decision to use this would be granting the patient is non-pregnant or is on birth control, okay, dual birth control methods in order to ensure that there is no danger of losing the child, okay, in case of pregnancy. Bismuth salicylate has a coating effect on the ulcer. It's either that one or we use I'll show you the other drug later. It's not on this page. I think it's under gastritis. Okay, okay, let's find the drug right now, so I might forget. Right here under gastritis, there's more drugs here. Same drugs used in peptic ulcer. We are on page 1268. So here are the same antibiotics mentioned in the table earlier under peptic ulcer, except now we have, so here's the same Pepto-Bismol. So it is a coating agent. Obviously, this will be used. So if it's a coating agent, meaning it will put a coating over the existing ulcer, protecting it from the acid. So when do you think is the administration?
Before eating.
Okay, so always taken on an empty stomach, because otherwise, what's its use if you're already eating? So it can no longer coat. Okay, so this will be given before meals, usually an hour before meals, allow it to coat the ulcer and then begin a meal. Okay. So same effect, bismuth salicylate or Pepto-Bismol has the same effect as sucralfate. Here, sucralfate, brand name Carafate. This is a big tablet, so they can either chew it or swallow it whole, depending on the patient. Again, the same as Pepto, 1 hour before meals. This can also be taken at bedtime because we do have acid secretion while we sleep. Okay, so this will also help coat the ulcer. Again, for sucralfate, administration is 1 hour before meals and at bedtime. Right? So that table was under gastritis. Okay. All right, let's continue here. Let's go now to monitoring and treating complications. Okay. Smoking cessation will help. This will smoking actually increases the gastric acid secretion, and therefore will help as part of the therapy. Dietary modification. If you read the paragraph, there's really no evidence that nutrition plays any part of treating an ulcer. What they're saying here is simply avoid certain foods and beverages because they're known to exacerbate the symptoms. But if you notice, there's really no food that they encourage in order to help heal the ulcer. Does that make sense?
Mhm.
Meaning there's really no evidence to use food to treat an ulcer.
Mhm.
All their guidelines here is patient eats foods that are tolerated and avoid those that cause symptoms. As simple as that. So if tacos are fine with them, eat tacos. If tacos cause pain, don't eat tacos. All right. So it's all trial and error with these patients. Right. Any questions about nutrition? Alrighty. So here, small frequent feedings are not really necessary. Okay. So there's really all of these are evidence-based. Surgery, we will skip. Let's go now to complications. First complication is hemorrhage. This is from a bleeding ulcer, meaning as the ulcer is exposed, no coating, then the patient did not comply with the therapy. For instance, acid erodes the blood vessels, causing acute bleeding. Can this lead to hemorrhagic shock? Okay. Here, bleeding peptic ulcers account for 27 to 40% of GI bleeds. And evidence of that would be vomiting blood, hematemesis, or pooping blood, melena. Melena is black tarry stools. Vomiting really depends on where is the blood or where is the bleeding. Is it in the stomach or is it in the duodenum? Upper GI, which is in the stomach. If it's an arterial bleed, of course, appears bright red. Or if it's a slow or venous bleed, then it will come out as coffee ground appearance, meaning the bleeding is slow and then the acid digested the blood. So it appears as coffee grounds when it comes out. Manifestations of acute bleed, no different from what we saw in hypovolemic shock. So fainting, dizziness, nausea, vomiting, and of course, what will happen to heart rate? Okay, there's tachycardia and blood pressure will. Okay, and along with respiratory rate increase as well. And of course, check for abdominal distension and then examine the color and appearance of the stools or the emesis. Okay, next paragraph. Many times bleeding from peptic ulcers stops spontaneously, meaning it stops bleeding on its own. Why?
There's no agitation.
Well, do we have a clotting cascade?
But
Yes, our body will naturally stop any bleeding. So any injury to the bleeding here is really a blood vessel, correct?
Mhm.
So the exposed blood vessel was damaged by the acid and started bleeding. Of course, that will trigger clotting cascade. And then once we have clots, it will stop. The key there is to prevent the recurrence because the incidence of a recurrent bleed is high. For example, if that clot is there, it stopped the bleeding, but then the acid continues to erode more blood vessels. So can it bleed again?
Yeah.
Yes, so that's what it means here of recurrence. So it can bleed again. So what can be done in order to prevent rebleeding? What will be given to the patient? I repeat, what's the cause of the rebleeding? The acid, okay? The acid will erode the blood vessels again. So therefore, what will be given? Okay, so PPI is part of the therapy to manage GI bleed. All right, so let's recap. So let's say anybody who comes in with a GI bleed, whether or not caused by a peptic ulcer, what is your expected protocol? Again, NSAIDs, we can't stop that all the time. Some patients have no other choice. Okay, we have to treat the pain. What will be given first? Let's say you have active bleed. So what will be given? Okay, fluids first, okay, depending on how, all right. So we check the hemoglobin hematocrit. It's what's the threshold again when we expect a blood transfusion? What number will be your hemoglobin?
Below 12.
Below 7. Okay. Below 7, they will give you an order for transfusion. And you're already familiar with the blood transfusion and transfusion reactions. So expect PPI. So PPI, depending on the degree of bleeding, the doctor will give you an order of either twice a day IV push, 40 milligrams, or a continuous infusion of a PPI. So it's either esomeprazole or pantoprazole IV that will be used.
Doesn't matter if it's a PPI or H2.
With in my experience with GI bleeds, if it's IV infusion, it's always pantoprazole. I haven't seen any other.
What about like
Infusion.
PO?
We only do PO once the patient is stable. Right. In fact, most therapies, if the bleeding is acute, again, if the patient shows active bleeding, it will be a continuous infusion of a PPI, or they'll give the PPIs twice a day. Morning, 40 milligram push over 2 minutes. Evening, 12 hours later, 40 milligrams, another 40 milligrams IV push. So anything higher than a 40 milligrams dose of either esomeprazole or pantoprazole has to be in a continuous infusion, right? So this will be your patient next week. So Valerie Cucina is a peptic ulcer disease patient. Right, so she's already open. You can see her, expect what orders. There will be a transfusion order there. There'll be antibiotics as well as PPIs. Okay. Between esomeprazole and pantoprazole, it's pantoprazole, which is Protonix, is usually used. And if the bleeding is continuous, then they'll have to take the patient to endoscopy. Okay. Once the hemoglobin stable, then they'll perform the procedure. They'll have to do either cautery. If the blood vessels are small enough, they'll burn them. If not, then they'll have to ligate the blood vessels.
Cut out the whole thing.
No, just you put bands or ligate it, tie it. Okay, So if the patient is actively bleeding, we will expect of course, we need 2 large bore IV access or a central line if needed. We will need to insert a NG tube. Now, the NG tube is not for feeding. This is to decompress the stomach. Now, which is safer, to suck out the blood or have the patient vomit it?
That's what I-
Okay, because vomiting, of course, means, yeah, the patient will have high risk for aspiration, right? Okay, so we don't want that happening, especially if the patient's already lethargic from the blood loss. So we will put an NG tube in place, put it to low intermittent suction to continuously suck out the blood and the acids. And what's the diet going to be? With any GI patient, whether or not your manifestations, your symptoms are nausea, vomiting, bleeding, it's always NPO, right? Patient will not receive anything by mouth. We will keep them alive with IV fluids. Don't worry. IVs will be administered unless the patient has other contraindications like kidney disease, end-stage kidney disease, or heart failure, for instance. But even with those conditions, we still give hydration. The rate, of course, will be slower. Okay, so how do we know there's perforation and penetration? We expect, of course, perforation. That means there's a hole now, right? It's either in your stomach or in your duodenum, depending if you have a gastric or a duodenal ulcer. So if there's a hole there, is the peritoneum sterile or dirty?
No, it's dirty.
The peritoneum is sterile. The GI tract is dirty, right?
The whole picture.
Right. So now if you have a hole in your stomach or in your duodenum, what will leak out into the sterile peritoneum?
Gastric fluids.
Stomach contents, or especially if it's duodenal, could poop come out.
Mhm.
Okay, so what was the consequence if you have
Sepsis.
corn kernels, tacos, or poop into the sterile peritoneum now?
Infections.
What do we call that condition?
That's all.
No, the inflammation of the peritoneum.
Peritonitis.
Okay, peritonitis. Now, peritonitis will lead to sepsis,
Okay.
okay? And we won't repeat sepsis anymore. Okay, but that's the sequence. Yeah, that's the order of the problem. So what we really don't want to do for perforation to happen, but it does occur. So how do we know there is perforation? Where do we find air? Inside the bowels or outside? Inside. So they'll get a CAT scan, and if they see any free air, meaning air outside the bowels, where did that air come from?
Inside the bowel.
From one or more bowels. Okay, so consider it like a fart. Okay, so the bowels farted and are trapped inside the peritoneum. So that's your evidence that there's penetration or perforation somewhere, and a very high risk for peritonitis. And depending on the patient's symptoms, if of course the peritonitis here will cause rigidity, right? Tenderness and rigidity in one area first, wherever the perforation occurred first, okay, wherever the leaking occurred, they will turn rigid there and very tender, but it will spread. If not stopped, then it will spread, and then the patient likely will end up with sepsis. Then now we have another problem. Here are your manifestations of perforation, and therefore this will also include peritonitis because you cannot separate them. Once there's perforation, and then you're guaranteed peritonitis. So there's sudden severe pain, and it may radiate. There's vomiting. Patient will collapse. That indicates the patient already has sepsis because blood pressure drops here. Then again, the tenderness and rigidity of the abdomen may not be diffuse yet. It may start only in one quadrant, and then it will spread eventually. Then here, again, you already know signs and symptoms of shock. Any questions on peritonitis? Okay. Another complication is gastric outlet obstruction. And here are your manifestations. For gastric outlet obstruction, this is the management. NG, just like GI bleed. Then followed by, of course, this will be connected to suction to empty the stomach. And then followed by endoscopy, okay, to clear the obstruction. I won't test you on the procedure. I mean, we're not doing it. The doctor, all our responsibility here, if the patient goes to endoscopy, is what? Yeah, again, we're not dealing with that. We're not the ones doing it. So what is our responsibility if the patient has a scheduled endoscopy?
On consent.
Okay, so make sure patient's NPO first and foremost, and then okay, education, what to expect, and then consent. That will be, of course, explained by the doctor first. They'll obtain informed consent. So be careful about how the question is rated, okay? Do we obtain informed consent?
No. The doctor does.
The nurse
Witness.
obtains
The doctor
informed
gets
consent.
it, we can witness. We witness and we verify.
We
that
can
it was.
obtain a signature, okay? We do not obtain informed consent. Why?
The negative.
Okay, informed consent means the patient was educated about the procedure, the risks and benefits, and then they assume all responsibility, that they understand. Okay, so is it our duty to explain?
No.
We can reinforce the teaching, right? So let's say they weren't clear about what the doctor said, but as long as that information wasn't the first time the patient heard it. Is that clear? Meaning you're simply reinforcing. Of course, they're in pain, they're in distress. Not all information was understood. So later when the patient asks, what did he mean again? So you don't have to call the doctor because are you familiar with what a perforation is? Yes, so therefore you can explain the procedure. Meaning that is not the first time that the patient heard it. You're simply reinforcing. And as long as their decision did not change, however, if there's second thoughts, okay, oh, I thought he said like this. I don't think I want to do this though. So if that affected that information, that lack or misinterpretation of the information affected the patient's decision, then you better call the doctor. Are we clear? Alright. That's about it. And teaching would be all related to the medications. You give education on how to use it. So let's review actually. If you know from farm, let's go back to the table. About the timing. You know what? Let's go to the gastritis because that was more complete. Although it's in the table though. Okay, here you have nursing considerations here. Okay, those are for antibiotics, the H2 receptors, blockers, PPIs. We're supposed to, okay, they don't have antacids. Now, these patients will also be on antacids, right? If you have an ulcer, you have peptic ulcer, would antacids be beneficial?
Yeah.
Okay, but what did you learn again about antacids? Say this patient is on antacids. How do you schedule the administration now? Let's say they're on antacids and they're also on these combinations. They have amoxicillin with clarithromycin. Then they also have the Pepto-Bismol or PPI and or a H2 receptor blocker. So how do you teach the patient when to take these drugs, knowing what you know about antacids?
The acid, the decrease of the acid production was on that.
Okay, let me clarify that. An antacid is not like a PPI. What you're describing is a PPI or an H2 receptor blocker. Both of those H2 receptor blockers and and PPIs reduce acid secretion. They do it in two different ways, but antacids do not affect acid production.
Yeah, it's because of it.
So what do antacids do?
They.
Okay, so they raise the pH. Okay, so we have two antacids, either aluminum-based or magnesium-based, or we have a combination. We have aluminum and magnesium, right? So you've heard of Maalox, right? Okay, so that's a combination. And we also have milk of magnesia, which is magnesium-based. And then we've got aluminum-based also. Aluminum usually causes constipation, magnesium causes diarrhea, right? So go back to antacids. So let's say I'm taking an antacid, which will help with acute symptoms. So what should I tell the patient?
Around 60 hours before.
Okay, make sure they're at least 1 to 2 hours before any medication, right? So just tell them, okay, so when do you normally take the PPI? For instance, PPI, what is the administration time of a PPI? Because it's once a day
In the morning, for sure.
on an empty stomach, right? So upon rising in the morning, okay. Unless the doctor orders twice a day PPI, which is rare in the outpatient, we only give twice a day PPIs IV in a hospitalized patient. Outpatient, meaning that patient's outpatient, so therefore they're stable, right? So they only get PPIs once a day. So that means they have to time the antacid. When do you usually take the antacid? Before or after eating? When does the acid produce?
Because it comes after that.
Okay, usually either with the meal or after the meal. For H2 receptor blockers, there's really no set time. I mean, you don't have to eat it, take it before or after a meal, because as long as you take it at the same time every day, because the H2 receptor blockers work differently than PPIs, although the end result is the same. Okay, that's about it. Any questions on peptic ulcers?